Thank you, and hello, everyone. I need to update the title on my slides, but the same gist. So yes, I'm Corey Arnold. I'm at the University of California in Los Angeles, and I'm in the Department of Radiology and Pathology. And I thought this morning I could just give you all a kind of high-level overview of some of the projects that we are working on. So I'm going to talk about applications of deep learning in both radiology and pathology, and then I'm going to touch on an integrated clinical reporting system that we've developed here at UCLA for cancer diagnosis that is going to become the platform for translating our image analysis algorithms into practice. So first, deep learning, I'll talk a bit about tissue fate in stroke, prostate cancer and MRI, and then I'll shift to pathology and talk about classifying Gleason grades on whole slide imaging, which is an interesting problem. But first, predicting tissue fate in stroke. So acute ischemic stroke is the primary cause of long-term disability, and beyond tissue plasminogen activator, the treatment protocols for stroke vary across stroke centers and physicians. Things are becoming more standardized with each clinical trial, but at this point, I would say protocols for intra-arterial therapies like clot retrieval or IA-TPA are just sort of beginning to grow and become standardized. We argue that perfusion imaging contains underused signal that may aid in the prognosis and decision-making of patients. So perfusion imaging, for those who don't know, is our MRI sequences where you inject contrast agent into the patient, and then you watch that contrast agent perfuse over time. So our research question was, can we predict eventual tissue death based on baseline perfusion imaging? If we could inform treatment decision-making, so we can kind of predict how large a final infarct or tissue volume will be. And we can also potentially learn quantitative stroke subtypes. So this figure just shows the basic overview of what we wanted to do. We have an input patch, and we have its tissue concentration over time down here. We can feed that into a CNN, and we want a convolutional neural network, and we want to predict whether this voxel of tissue will be alive or dead after treatment, which is about 3 to 5 days is when we do a follow-up. So we got 48 middle cerebral artery stroke patients from our imaging repository, our PACS. We did some standard pre-processing. We had to do registration and skull removal, but we then did some Gaussian noise filtering and some other zero mean and unit variance standardization. You can see some of the demographic and clinical presentation information for the patients here. So one criticism we got when we submitted this for review that is kind of common in this area of research in convolutional neural networks is how big is your training patch size? So the thing to notice is we are classifying, you see this red X here, that represents a single voxel, and that's what we're classifying, but we're giving the network actually a 25 by 25 region, right? So we're going to use neighborhood information around the voxel to classify whether or not this voxel will live or die. And we get criticism often, well, how do you know 25 by 25 is the right size? So just a side note here, we actually ran a whole bunch of different patch sizes that you can see on here, and we then calculated the area under the curve in terms of performance for each patch size, and we kind of decided, you know, at 25, we seem to kind of level off a bit. So our patch sizes were 25 by 25. We constructed a couple different neural networks. I won't go into too much detail about these. The first one was a two-dimensional convolutional neural network. So we did convolutions with two-dimensional filters. We then also implemented a three-dimensional CNN, which we can see here, where we did convolutions over 3 dimensions. Okay. And so again, our input patch size is 25 by 25, and then we have 64 time steps. So it's a three-dimensional input. And then, of course, at the end, we have a softmax layer and a few fully connected layers. And so we predict whether or not the voxel will be alive or dead in 5 or 6 days following a stroke. So we had some okay results with that model, but they weren't as good as we expected. So we then began thinking about other ways to improve our results, and we said, well, in the brain, we have kind of a natural control in stroke. So the brain is symmetrical, and strokes are largely or primarily one-sided. So if we can compare the two sides of the brain, maybe we can do better with our predictions. So we have four possibilities in terms of patches for these comparisons. We can have the two sides alive, or alive and dead, dead and alive, or dead and dead. That last one doesn't really occur. I don't think it occurs at all in our data set. So now we're going to train the network, as you can see here, with the input patch of interest, say this red patch, and its contralateral patch. Okay, and so hopefully now we can learn kind of relative differences between stroke-affected regions and unaffected regions. So you can see we learn these filters pairwise. The patches are connected into their feature maps, and so we'll be able to learn the relationships, and you'll see that in the end between the two sides. And again, we have a softmax output of dimension 2. So what did we do? We got 96,000 training patches that we balanced at 0 or 1. We did a 10-fold patient cross-validation, and we implemented some baseline models, including a general linearized model, spectral regression, kernel discriminant analysis, and an SVM. We then compared our 2D, 3D, and what we call the unit CNN. So we then, within the unit CNN, we implemented the contralateral patch like I described. We also implemented a random, so we would put in the patch of interest and some randomly selected patch, just to make sure that contralateral actually was doing something. And then we did a duplicate patch, so the patch of interest, and we just duplicated it and sent it into the network as well. If you look at our AUC diagrams, we can see that our unit CNN with the contralateral patch outperforms everything else. So it does appear that having sort of that control comparison helps to predict whether or not voxel will die. And these are the filters we learned, so we can look at the first layer of the network and see what the filters look like. So these are the pairs of filters, just 7 of our 25 examples. I think, well, no, we have more than that, but these are just 7 that we cherry-picked, I guess. So you can see the time step, 0 to 64 again, and then the intensity at each point in time. And so the thing to notice, for example, filter number 7 right here, its pairwise is that it begins dark and then gets very bright on this patch, and on this side it's brighter first and then gets dark. So this sort of represents the scenario where one side of the brain has delayed perfusion. So when the contrast perfuses, the signal gets bright, and the other side of the brain has normal perfusion. So if we look at the random patch, so the patch of interest and a random patch, we don't really see any relationship between the filters. And if we look at the duplicate patch, we see in general that the filters are the same, and that's because they have the same input. So here's what some of the prediction results look like. Patient 1, this is the flare. So this is, you use flare post 5 days to see what truly died in the brain, and that's these hyper-intense regions. So this was the ground truth. These are what our various methods predicted. So you can see the unit CNN does pretty well. In general, though, and you can see it here, we noticed that we sort of tend to over-predict, especially here, for example, in the patient number 3. And we're not sure why that occurs. One confounding factor in this analysis is that we're totally ignoring treatment. It's very difficult to control for treatment because there's such a wide variety of what these patients receive, because sometimes it depends on the fellow on call. But that's something we're trying to control for. So we have some other projects in acute stroke, another one being estimating stroke onset time. So right now, protocols state that if you're within maybe 4.5 or 6 hours, you can get IV TPA, but after that, you're ineligible. Up to 20% of people wake up with a stroke, or they're discovered by someone unconscious with a stroke. And so if we don't know when someone's stroke occurred, they are not eligible or TPA, even though they are within the treatment window. They could be within the treatment window. So we're trying to now classify when a patient's stroke occurred based on their NP-MRI imaging. And we're using kind of a deep autoencoder framework to extract features along with an SBM. And right now we're getting about 0.68 AUC. I think we've done better than that since I put these slides together. Another project in stroke is to estimate perfusion parameters. So currently people use deconvolution techniques to deconvolve the signal from the arterial input function to come up with perfusion maps. They can be inaccurate in the presence of noise. So we have a model that treats it as a pure pattern recognition task, where we feed the deep network the concentration time curve and the arterial input function, and we try to predict perfusion characteristics. So cerebral blood flow or Tmax. So this is the time it takes for a voxel to reach its maximum contrast peak. So moving on from stroke, wanted to share a bit about what we're doing in prostate cancer. So prostate cancer is the most common newly diagnosed cancer in men in the US and the second deadliest. The gold standard diagnosis is biopsy, but there are some substantial limitations with biopsy that I'll show. And both biopsy and surgical resection have associated morbidity and mortality. So they're not, they're invasive procedures, obviously. And making treatment decisions can be difficult, especially in men with sort of low-grade prostate cancer, right? These are people that have slow-growing prostate cancer, and it's unclear if it will ever be lethal, or they would expire as a result of something else. So our research questions in this area are: can we develop an image analysis algorithm that can improve the quality of NP-MRI regions of interest for targeted biopsy? So right now, our radiologists here at UCLA review MRIs of the prostate, and they delineate regions of interest, high suspicion. And then we have a couple different targeted biopsy procedures where those regions are targeted. The more general biopsy procedure of the prostate is a systematic biopsy, where a grid of needles is inserted into the prostate and extracted. So we're just trying to sample everywhere, versus at UCLA, we do that grid of needles, but we also target based on imaging regions. So such an algorithm could also make a useful estimate of risk in regions that are difficult to biopsy. We could create a quantitative imaging biomarker that would improve efficacy of active surveillance. So at UCLA, we have an active surveillance cohort where men with these intermediate prostate cancers, we don't treat them, we just sort of watch it over time and see what happens. And what we'd really like to do is, in combination with clinical features, we'd like to produce an overall prediction of the likelihood of clinically significant prostate cancer that could allow for deferral of biopsies in some patients, okay? So we know we're doing too many biopsies. Can we discriminate better who should get a biopsy and who doesn't need one? So here's an example of our MR ultrasound fusion biopsy outcome. The blue dotted region denotes the prostate, the light blue. The green region here is the ROI generated by the radiologist, so this was suspicious for cancer. The red region is the actual cancer area that was delineated by the pathology following resection of the prostate. The dark blue needles represent the biopsy cores, and the orange needles are positive biopsies. So there's a few things to see that sort of illustrate problems with biopsy. Good, we have negative biopsy cores taken outside the cancer, and here it's these orange ones are good. These are positive cores within the cancerous region, but then we strangely see a couple negative within the positive cancer region, and this can happen for a variety of reasons. The tumor is not homogeneous. These could have been necrotic regions or something that were not cancerous, or the throw of the needle might have just missed it. So there's some inherent problems with our biopsy procedure. So what we did was we fit a fairly straightforward convolutional neural network to the data. We took the T2 signal, the apparent diffusion coefficient signal, and then a couple perfusion maps. So in prostate, these are KEP and K-trans. These are just perfusion data. And the 3D T2 ROIs, so these are the ROIs that the radiologist drew on the images from 82 patients. We then had to register this data using a mutual information-based method. That's kind of a complicated procedure. And then our ROIs were dichotomized to containing Gleason 7+ or not for the purpose of a ground truth. So we kind of simplified here. Aggressive cancer is Gleason 7 and up versus less. And Gleason is just a cancer grading system for those that don't know. So we then fit a 4-layer CNN that we trained using 8-fold patient-level cross-validation. So this is just a picture of the inputs and then the various layers and the output. Here are our results. So this is actually ROC curves over our 8 different folds, test folds during training. And here's a diagram showing our predictions. So red are what we predicted, and green are the radiologist's ROIs. So a few things to know. We got moderate performance using our 4-layer network, but we got reasonable recall. We got poor precision, so we had a lot of false positives. We're currently improving this with more data. In addition, rather than using the radiologist's ROI, which we saw on the previous slide, we know is not fully accurate, we now have a gold standard that uses the surgical pathology. That was complicated because we have to register surgical pathology to MR space, which took us a little while. We have more complex models, and we're looking at using additional target classes. So staying within the prostate, we are also looking at whole slide imaging. So just a bit about whole slide imaging. It's a massive amount of data. So this is a lung wedge resection with H&E staining, and it has about 5.5 billion pixels in it. To give you a sense of that scale, this is what it looks like at full resolution, this little speck. For those who have done image analysis and are familiar with the CFAR10 database, it would fit entirely within this part of the image. So that's 32 by 32, or 60,000 samples would fit right there. And then most people have probably heard of ImageNet, so it would only take 510 of these lung wedge resections to recreate ImageNet, which is about 2.8 trillion pixels. So it presents some interesting challenges for deep learning. So Gleason grading. The Gleason scale goes from 1 to 5, with 5 being the most serious differentiated, non-differentiated cells. There's low to moderate inter-rater agreement, especially with general pathologists in performing Gleason grading. So this is where the pathologist looks at the structure of the glands in the prostate and assigns a cancer stage score. So we're interested in developing an algorithm that can improve the reproducibility of cancer grading. So at UCLA, at least, we have pathologists, and they all do it slightly different. So it'd be nice to make that uniform. And we're interested in extracting informative and hopefully predictive pathological features. So the challenges include that it's a computationally intensive problem. We have a mixture of tissue contents, right? So a Gleason 5 slide can actually contain Gleason 5, Gleason 3, Gleason 4, benign glands, and stroma. So the pathologist only grades the highest Gleason score. They actually grade the first highest and the second highest. So if you have a biopsy that is Gleason 3 plus 4, that means that most of the cancer was 3, second most was 4, but there could have been, people don't usually grade 2, but there could have been 2. There's also a large visual variation of the tissues. Current approaches perform classification on pre-selected ROIs or do a binary segmentation. So they just look at benign versus malignant. They don't try to classify by Gleason type. So our data for this set consisted of 20 patients with a diagnosis of Gleason 3 or 4. We had H&E images that were tiled to 1200 by 1200 tiles. You can imagine this staining process is performed by humans, and there can be a lot of differences in techniques Some slides are overstained, meaning they're a lot darker. Some are understained. The slide that's been sitting around for a few years the stain might fade as well. So we do stain normalization using a color transfer process. And then 3 pathologists segmented the glands on 224 of these 1200 by 1200 tiles. And you'll see what that looks like in a few slides. So our methods were to perform pixel-wise classification of stroma, Gleason 3, Gleason 4, and benign glands. We used several models. We used a patch-based CNN. We used an SVM with engineered features. We used a U-Net, and then we created a multiscale U-Net. So a bit about the U-Net. The U-Net architecture combines features from shallower layers with those from deeper layers. So what you have is this contracting path downwards that captures context, and a symmetric expanding path or up convolution path on the right that enables precise localization. So what we did is we took information from patches at 3 different scales to train our U-Net. So we took, here's sort of an input patch, 1200 by 1200, and we took a big patch, a medium patch, and a small patch, and all 3 of these patches were used to classify this 100 by 100 by 3. It's an RGB patch. Our results, so we had a patient temple cross-validation. The CNN was split into test and train because you just can't use a CNN when you have 5.5 billion pixels. And we then used the Jacquard index, which is just an intersection over union score to evaluate the models. But we see that the multiscale U-Net performs the best. It performs very similar to a regular U-Net, although in some areas, we don't have significance tests for these. It's very close. The pixel-wise CNN just doesn't do a very good job. And the baseline method from our collaborator, we outperform that as well. Here are some of actual images. So you can see what a challenging task it was to manually annotate these. So here's the ground truth mask in the 3rd column. So each color is either stroma, blue, or a gland. So here we see red is Gleason 4, pink is Gleason 3, and green is benign. Okay. You can see our multiscale U-Net versus the regular U-Net and the ground truth, and then the input tile. So the single-scale input U-Net misclassified areas with dense nuclei on a large benign gland, so right here, because it didn't have a large enough context window. But with the multiscale U-Net, we are able to segment it correctly. However, segmenting poorly formed high-grade areas is difficult. Here you can see sort of high-grade, not well-differentiated glandular structures. If you look at the ground truth mask, I think you can also identify how difficult a problem this is for the pathologist. I mean, this is what the pathologist was given, and this is what they came up with. So it's kind of challenging. So we have a lot of work ongoing in this area, including implementing generative adversarial networks to try to do some anomaly detection and other things like that. So finally, I just wanted to give an overview of the clinical system I mentioned at the beginning for integrated reporting. So this system is designed for cancer diagnosis at the moment, but we're expanding that. Cancer diagnosis is complex and burdensome. There's multiple specialists, right? There's oncologists, there's radiologists, pathologists, surgeons, pulmonologists, et cetera. The number of tests are increasingly complex and many, and the process is time-consuming and error-prone. So right now, everyone kind of operates in their own little silo. The radiologist does their job, the pathologist does their job, and there's no integration of the different diagnostic signals. So we set out to try to improve diagnostic alignment to prevent delays and errors, and we wanted to ensure the appropriate ordering of subsequent diagnostic tests. So what our platform does is it combines radiology and pathology workflows and generates a single aligned report for the treating clinician. So this is what it looks like. The pathologist completes their interpretation of the tissue sample. There's then a HL7 trigger to our application that sits in a cloud infrastructure. Once we receive that trigger, our application goes off and hits the various clinical databases within the UCLA Health IT system. So we have our PACS, our whole slide imaging, our EHR, our lab system, which is Beaker, and our imaging system called Radiant. Most of these are Epic. And we pull the relevant information from those systems and we put it together into this integrated report. We then have some logic that checks the diagnostic findings between the radiology and the pathology reports, and will attempt to automatically determine if those reports correlate or not. If there's incongruencies, we alert the radiologist, who then reviews, and they may or may not need to talk to their pathologist colleague. Eventually, they reconcile, and the report is finalized and sent to our EHR and treating clinicians, and it's also used at our multidisciplinary tumor board. In fact, this whole process is a bit like having a tumor board for every patient. Briefly, this is just what the overview assessment page looks like in the report. So this is one of those MR ultrasound fusion biopsies that you saw earlier. So we highlight the pathology summary, where we have a highest Gleason grade of 7. There's a radiology correlation, so here it has to get correlated. And the comments are the PIRAD, so this is an imaging suspicion scale for the prostate. So PIRAD's 3 out of 5 target lesion is confirmed cancer. And then we also show kind of the important imaging for the case. The other thing I just wanted to highlight is this image analysis tab. And so this is where we are planning, as we publish and validate our analysis algorithms, we are hoping to put the results. So right now we have kind of a 3D mesh map where the user can rotate the prostate and see the cores from the biopsy and what their grades were. We have a population map where we took several hundred prostates from UCLA and registered them, and then created a heat map of where we see cancer here. So you can kind of contextualize the current patient given the population we see at UCLA. And our Gleason classification algorithm isn't live yet, but we're working on it, and it would just do quantification. So here we see a table of the percent stroma benign and the various Gleason grades. So with that, I thank everyone for their attention. I'd be happy to take any questions.